Hello, I'm Dr. Markle and welcome to this webinar on perimenopause and menopause, which I hope will serve as a backbone of support you can keep coming back to, along with the reading material download on the website, as you reach this transition phase in your life. I hope to arm you with knowledge and sustainable lifestyle shifts that can make this a positive time to empower yourselves and to get your bodies strong now so that you have really strong bodies that function really well when you're an old lady. After watching this presentation on menopause and how to manage it, there is a second part which focuses on the lifestyle aspects. If you wish for further support, please contact your practice. We recognise that there are people who are assigned female at birth who don't identify as women. Those people have a particular set of needs that wouldn't be covered in this presentation. So in this presentation, I'll be talking about women who are assigned female at birth. So why are we talking about the menopause? The aim is to share information on menopause which is correct and evidence-based, and that you can use to arm yourself with understanding. Through this webinar, we're going to look at the impact of the peri and menopause on women, defining and understanding menopause, understanding symptoms, and the impact on long-term health and what you can do, and what can help. And as I mentioned, we're just going to focus on HRT in this presentation. This is a great opportunity to make gentle changes in your lifestyle. By lifestyle, I mean diet, exercise, stress management, and sleep support, which will be in part 2. As you may find that the ways of functioning that worked for you before are not serving you as well through this phase of life. For example, those exercises that worked for you before may not be getting the results in the same way. Or you may find that the recovery from exercise is harder now. Some foods may be better options now to give you more energy support, and some alcohol may just not sit well with you anymore. Creating those gentle shifts and trying out what might serve you better in the long run is what this webinar is about, through lifestyle or HRT if you wish. It may come across that we may spend a lot of time on HRT as a topic. This is because there is a lot of understanding I wish to give you. As you know, there are tailored options for you. HRT is not a one-size-fits-all, and there are huge benefits for you in the long-term health if you did think this was an option for you. For example, one lady may have migraines, so a patch is a better option for her. Another may have sleep issues, so taking the body-identical progesterone tablet at night is a better option, with estrogen applied to their skin, and so on. So let's give you that knowledge today. So why? The impact of menopause. There's a huge impact on women from the menopause, and I'm glad that the media is talking about this more. For example, women report an average of 7 symptoms each. 50% said menopause had impacted their home life. 3 in 5 women said menopause had a negative impact on their work. 2/3 are less able to concentrate. 58% experience more stress. 1 in 10 had to leave a job due to symptoms. Some reasons I've heard women take sick leave or go part-time are from headaches, from brain fog, she says, anxiety, an inability to juggle all the spinning plates at this time of life. Women do not seek enough help. 50% of women aged 45 to 65 who've experienced the menopause in the past 10 years had not consulted a healthcare professional about their menopause symptoms. But on the flip side, research has shown that they do attend GP more in this time of life, for more appointments, for other reasons which are caused by the shift, but not necessarily realising the link to their hormones. Let's define these changes. So menopause occurs when the ovaries stop functioning and your periods end. This is defined as 12 months after your last menstrual period. The average age in the UK is 51. Perimenopause is those first biochemical or blood changes or physical changes until 12 months after your last period. Postmenopause is 12 months after your last period. Surgical menopause is menopause when the ovaries are removed in a procedure such as oophorectomy. Medical menopause is menopause as a result of medical treatment such as chemotherapy. Early menopause is menopause between 40 and 45 years old, and premature ovarian insufficiency is menopause less than 40 years old. Perimenopause is harder to define, but shifts can happen as early as in your late 30s. the periods shift a bit, the PMS symptoms deepen, and those women who've had tough times in adolescence or after babies may notice that they find this shift too particularly hard. 95% of women get some form of PMS, and 5% may experience significant difficulties. Symptoms may resemble PMDD, premenstrual dysphoric disorder, where things are so mentally tough, your ability to function is really impaired. If you think you have features of this, please chat to your surgery for targeted help. So let's chat hormones. We're going to focus on estrogen and progesterone. Estrogen is made in your ovaries and it's dubbed your female hormone, which leads to the development of the female characteristics at puberty, and it has control of the menstrual cycle. As we age, the number of eggs decline, we have less estrogen produced, and we get the symptoms of peri and menopause. In essence, estrogen getting lower is the cause of peri and menopause. And then we have progesterone. So this is released in the second half of the cycle and it prepares the uterus, the womb, for pregnancy. And it's easy to forget that the purpose of the menstrual cycle is to prepare the body for pregnancy. So perimenopause. This is the time spent in the lead up to the last period. And it's the hormonal variation that leads to the symptoms. Initially, pre-MS symptoms can worsen before your typical menopausal symptoms. The typical age of menopause in the UK is 51, but it's important to note this is younger in minorities, up to 10 years younger. So perimenopause for a British Asian woman like me could be typically my mid-40s. And symptoms do happen and can still happen whilst having periods. But they can also happen without periods if you have something like the Mirena or on a certain contraceptive or have had procedures like an ablation to your womb. And don't forget, in this period, you still can get pregnant. So looking at this graph, it's easy to see that there are huge fluctuations in your hormones at perimenopause, and therefore also why blood tests in this period are not so useful. Lots of these fluctuations are within the normal range of hormones. So it's much better to go on how you feel and your symptoms. Moving on to symptoms, physical symptoms. These can last for years, but usually settle after the menopause and can be either 7 to 10 years either side of the menopause. These may be hot flushes and night sweats, joint and muscle aches, changes in your period. They can get lighter, heavier, change in volume. They may be irregular. There may be sleep disturbance. There may be vaginal dryness. There may be urinary symptoms, needing to go more often, frequency, needing to go more urgently, or recurrent urinary tract infections. There may be palpitations, there may be headaches, there may be tinnitus, which is buzzing in the ears, breast tenderness, weight gain around the middle, and thinning hair or dry skin. So ways that women describe this to me are hot flushes. Oh, I'm running hot. I'm suddenly drenched in sweats. Some women may come to me with new joint pains, which are hard to pinpoint. Sleep is poor and makes it harder to function. Recovery is poorer, including after exercise, or vaginal symptoms, a feeling of bladder irritation, or not quite a urine infection, or actually having more urine infections, and discomfort during sex. Psychological and cognitive symptoms. Cognitive means how our brain functions. There may be low mood, anxiety, irritability, worsening PMS, rage, brain fog, or fatigue, which is persistent tiredness or a lack of energy. Women describe this to me as issues at work. Being a leader is harder. Low mood, crying or getting anxious about new things, restricting their activities, such as driving. Imposter syndrome. My confidence has gone. I don't know who I am anymore. I've lost who I was. And relationship issues. And this wonderful description of fizzing with rage. And brain fog, describing issues with memory and concentration. The relationship issues are probably the first thing years ago that was noticed by partners. HRT advertising like this, when it was first released, was aimed at husbands to make wives more pleasant to live with, which I have no words for, but I'm glad we've moved on from. So through this presentation, I hope that this is a really important take-home message. Estrogen loss affects other parts of the bodies as well. Bones. Our bones become less strong and more likely to develop osteoporosis. Like I said before, we can aim to keep our bones in older age strong and able to function well. Cardiovascular system, this is our heart and our blood vessels, because estrogen protects these and it becomes lower as we go towards menopause. So there is an increased risk of stroke and heart disease. We still typically think of men being more likely to have heart attacks and stroke, but actually it's hugely impactful for women. So how do you know where you are? Diagnosis is made on symptoms, and those variations in hormones mean that blood tests are not accurate. And you should not have a blood test to diagnose menopause if you're over 45. However, blood tests may be useful to rule out other causes, such as a thyroid issue. And sometimes symptom trackers can help you work out what's going on. But it's not all bad news. There is a Chinese saying that menopause is our second spring, and it's especially true with the rise in life expectancy. The average age in the UK is 83 years for a woman, so we're spending over half our lives in peri and menopause. So many women see this as an opportunity for gentle shifts in lifestyle at this pivotal time to generate better future health. And I really emphasize small, sustainable changes that you can build up in order to change your lifestyle and your narrative towards a better health for longer, starting when you feel those shifts happening and using this as evidence to support your mindset. So what can help? HRT, diet, exercise, stress management, sleep support, complementary therapies, and CBT. Let's start with HRT. HRT replaces the hormones which decline in your body around the time of the menopause and perimenopause if you have symptoms. So HRT is a two-step process. Estrogen and progesterone. Body identical estrogen, 17-beta estradiol, is estrogen that is human-made, but is the same structure to that which is made in your ovaries. This is great because delivering estrogen in this form is much better tolerated by you and you're less likely to have side effects. The body identical estrogen is derived from the yam plant, so it's vegan too. You can replace your declining estrogen in two ways: tablet or through the skin via patch, gel, or spray, which has no increased risk of blood clot. There is a small risk with estrogen tablets. You need to take or apply your estrogen every day in your preferred form. Patches are changed once to twice a week. Step 2, progesterone. If you have a womb, you need to have a progesterone. Estrogen and progesterone work together in the womb during the normal menstrual cycle. Estrogen encourages the lining of the womb to grow and thicken in anticipation of pregnancy, while progesterone organizes that growth and keeps it uniform. When the progesterone level lowers later in the menstrual cycle, this stimulates the womb to shed and bleed with your period. It can be helpful to think of progesterone like the cement that binds estrogen bricks together and ensures the lining doesn't overgrow. When the cement is removed in the later part of the menstrual cycle, the wall crumbles and you have your period. Giving estrogen bricks without progesterone cement can lead to disorganized growth of the womb lining, with an increased risk of irregular bleeding and womb cancer. Progesterone must always accompany estrogen HRT when you have a womb. So the options of HRT with your progesterone, are combined with estrogen in patches and capsules, the Mirena coil, which lasts 5 years, or micronized progesterone, which is body identical progesterone, which has this wonderful side effect of helping with sleep and has a lower risk of breast cancer. Many women, particularly when there are regular or problematic periods, find that Mirena intrauterine system or coil is an easy way to have your progestogen. The Mirena provides contraception, bleed control, and protects the lining of the womb as part of your HRT, and overall has a low progesterone absorption into the body as a whole, and it lasts for 5 years. In Preston Park PCN, you can book this to be fitted via your GP reception. So this is a slightly busy slide about how progesterone is taken, which is a little bit more complex, and I'll explain without the text, and the text is picked out from the reading material on the website to come back to if you need to. So estrogen is taken or applied every day in your preferred form, but the progesterone is slightly different, depending on whether or not you're still having periods. If you still have periods, even if they're not regular, then you take the progesterone for half of the month. If you have stopped your periods, you take it continuously. We can go through this if you're prescribed it, and it will also be on the packets. So HRT benefits. 1. Symptom control. 2. Bones. The improvement in bone strength and reduced risk of osteoporosis, which is bone thinning, and fractures. And 3. Your blood vessels and heart, your cardiovascular system. Reduction in heart attacks and stroke and death. And this is true of starting HRT within 10 years of your menopause or before the age of 60, after which there may be less benefit and slightly higher risk. So when to expect symptom control? Really, within a few weeks, which is amazing. Initially, a 3-month prescription is given, so you come back and review how you're getting on. You may need a change of dose or form and to monitor your response. Then once you're happy on the dose and form, we'll do a minimum of yearly reviews at your practice. HRT risks. For the majority of women, the benefits outweigh the risks. There is a risk of venous thromboembolism, which are blood clots. This is only with the oral estradiol and synthetic progestogens, not with the HRT applied to the skin or the micronized progesterone. Synthetic or human-made progestogens can offer contraception and improved bleeding, which may be a higher priority than a lower risk of breast cancer for some women. And also breast cancer risk. There is a small increased risk of diagnosis with combined, which means both estrogen and progesterone, HRT. There is no increased risk of death. The lowest risk is with micronized progesterone and dihydrogesterone progesterones. There is no increased risk for the first 5 years of use. But really, we need to put any risk into context to understand it a bit better. So this is a great infographic helping make sense of the causes of breast cancer when thinking about HRT risk. This is per 1,000 women in the UK aged 50 to 59 and shows the approximate number of women who will develop breast cancer in the next 5 years and the causes for this. So going from the top and coming down, of 1,000 women, approximately 23 will develop breast cancer. There'll be an additional 4 cases per 1,000 in women on HRT. 4 fewer cases per 1,000 women on estrogen-only HRT. Remember, this particular risk comes from the progestogen, and if you have a womb, then you need to have a progestogen. The breast cancer risk coming down the list compared to women on the combined pill is similar to HRT, as is the case for women smoking, but drinking alcohol, as you can see, and certainly living with obesity convey much bigger risks. So what is so vital to note is that the reduction of breast cancer risk in women who are regularly exercising. Also, within 5 years of stopping HRT, this increased risk disappears. Some women will have higher or lower risk than others. This varies depending on our genes, our bodies, our lifestyle, and our surrounding environments. There are some factors you can't change, such as your genes. But as this shows, you can lower your risk of breast cancer by being regularly active. Certainly, those women who have had breast cancer need to have a more personalised conversation about HRT. Often the usual form of HRT hormones is not suitable. So HRT is contraindicated, so it's not advised if you have a history of breast cancer currently or in the past, due to concerns about increased risk of recurrence. But you can speak to your surgery about whether you need a more specialised conversation, and we do have a specialist menopause clinic within our PCN. This presentation will still be useful to support your health around this period and your symptom control generally. HRT side effects. These are usually short and mild, such as breast tenderness, headache, nausea, fluid retention, and bleeding. If the bleeding persists, this needs a review. The change of dose or route can help support symptoms if needed. Nearly everyone can have HRT. You can usually have HRT if you have a history of high blood pressure, a blood clot, living with obesity, or family history of breast cancer or migraines. Making the right choice for you depends on what you want: a history of side effects, your medical history, risk factors such as weight, smoking, blood pressure, your family history. But I hope that the information so far shows that everyone's journey is a little bit different, but do think about what is right for you and do feel you can ask. Most women will experience vaginal symptoms at some point in their lives due to the lack of estrogen, affecting the tissues from the vulva to the vagina and from the urethra, where you pass urine out of, to the ureters, the bladder tubes, to the bladder lining. Vaginal symptoms may be vaginal soreness, dryness, pain during sex, urinary urgency, needing to go more often, nighttime urination, recurrent urinary tract infections, or smears may be more painful, so don't avoid these. But help is quite literally at hand. These symptoms can happen even if you're having systemic HRT. For vaginal, vulval, and urinary symptoms, estrogen can be applied directly into the vagina without the need for additional progesterone for vaginal symptoms only. Estrogen is poorly absorbed into the body as a whole from the vagina, so there is no increased risk of womb cancer when taken this way. The vaginal estrogen can be used on its own if you're not using HRT, or with your HRT for those local troublesome symptoms. There are a few different forms of taking it. There are pessary tablets you insert into the vagina, cream, or the vaginal ring. Other things that can help are vaginal moisturizers, just like for your face, but for your vagina to feel it has moisture. Over-the-counter or prescribed versions of moisturizer include Yes, Silk, Replens MD, Vagisil Hydrate, or coconut oil. And don't forget your pelvic floor exercises, and that there is a whole physiotherapy specialty dedicated to the pelvic floors via the Women's Health Physiotherapists. And you can self-refer yourself to them via the Sussex MSK website. There is also the NHS Squeezy app with regular reminders through the day to do your pelvic floor exercises. But do bear in mind that they do go off through the day. I had one come up in my work meeting recently, so it's worth noting. So alongside talking about vaginal soreness, there may be other factors which contribute to low libido, which is poor sex drive. This may be poor sleep, relationship issues. The relationships will shift with time, as does libido and desire, and that's okay. But managing this is hard. There's a couple of books in the reading list, including Mind the Gap and Come As You Are, which can help address this. The stress and low mood. This may shift with HRT and exercise. I've seen women see improvement in their symptoms, so less brain fog, so less work stress, better exercise, so better body image. And then there's a shift to a more positive cycle of behaviour. There may be vaginal symptoms or pain during intercourse, and change in the type of desire women have in relationships as time goes on. There may be low testosterone, and it may just be life and spinning all the plates that we do. And often perimenopausal symptoms hit just as you're coming out of the young child rearing age, where you're just trying to get back to yourself, which is tough. Testosterone. The ovaries also make testosterone. The level of this hormone declines with age from your 30s, but it does not have a dramatic drop in the menopause. Testosterone is used for the treatment of low libido, low sex drive in menopausal women. Testosterone prescription is technically off license for females, but where appropriate, male products can be used in low doses. And this is considered when other factors have been reviewed and treated and you are on systemic HRT. When taking testosterone, you need to have regular blood tests to ensure safety, and it can take 3 to 6 months to become effective. There are some uncommon side effects, such as acne, hair growth, and weight gain we can talk about. Estrogen is also important for libido, and I think we won't focus on testosterone too much, but know that it is an option to discuss with your practice after HRT for libido. Contraception. HRT is not contraception, and you often need to consider additional contraception, such as the progesterone-only pill, Mirena coil, or condoms. If you are less than 50 years old and your periods have stopped, guidelines recommend carrying on with contraception for 2 more years. If you are over 50 and your periods have stopped, contraception is required for an additional 1 year. If you are not having regular cycles due to hormonal contraception, and therefore you can't tell where natural cycles have stopped or not. Guidelines suggest contraception until 55. Ultimately, how you choose to move forward is your choice. There is so much information and misinformation on the internet, so try to look for what is evidence-based. I really hope you find those solutions that are sustainable and manageable for you. Thank you so much.